Hello, everyone. Welcome to today's Distinguished Researcher webinar. Thank you all for being here. The title of today's presentation is Building the Therapeutic Relationship in Diverse Asian Contexts. Today, we're welcoming our presenters, Harold Choi and Poornima Bhola. Harold Choi is an associate professor in the Department of Educational Psychology at the Chinese University of Hong Kong. His research interests include psychotherapy process and outcome, training and supervision, multicultural issues, and school mental health. He is currently the president of SPR Asia. Poornima Bhola is a professor at the Department of Clinical Psychology in the National Institution of Mental Health and Neurosciences in India. Her research interests include psychotherapy processes and training, youth mental health, and mentalization and personality dimensions. She leads the Menten Research Division, exploring mentalization processes, assessments, and interventions, and is currently the vice president of SPR Asia. I will just mention that questions will be taken at the end of the presentation. However, please feel comfortable and encouraged to leave questions in the chat throughout the presentation, and they will be addressed at the end. So dear presenters, whenever you're ready, you can begin.
Hey, thank you for the introduction and invitation. So I'm going to share screen first. Hang on. Share screen. Is it good? Full screen? Okay. So this is the topic, building the therapeutic relationship in diverse Asian contexts. So Poornima and I are going to talk about several things today. First, we are going to introduce the background, what is Asia and what is the diverse Asian context that we're going to talk about. Then we're going to talk about different topics, for example, stigma of help seeking, construction of the therapeutic relationship, specifically focusing on the hierarchical relationship in the Asian context, as well as the role expectations of our clients and therapists. Then we are going to move on to talk about emotional exploration, further, especially in the Asian context. Then we're going to switch gears a little bit to focus on training and supervision. And finally, to talk about some of our reflections, and hopefully that we are going to engage the audience in a meaningful and rich discussion on this topic. So the first question is, what is Asia and how diverse is Asia when we talk about the diverse Asian context? So if you can see here, this is a map of Asia, and Poornima and I had a very nice discussion about how to choose the map of Asia. There are different maps that we can find online, and it gets a little political, how people draw boundaries and who are in what areas of the map should belong to which country. And so we decided to use a more less clear map, so to speak, something that does not really mark by the countries, but actually to show you the terrain and also to show you how big Asia actually is. If you look at the next slide, we look at some of the statistics from Worldometers, and we can see that Asia actually is the most populous continent, consisting of 4.8 billion people. And it is also it is the densest in terms of density. So we have number of people per kilometer square. And this is followed by Africa, Europe, North America, South America, and Australia, Oceania, and finally Antarctica. So as you can see, this is a really big population, and that's why there's a lot of diversity, especially in terms of the number of countries. There are actually 48 countries in Asia, according to the UN, and that is not including Russia. And so to show you the map again, what we want to show you is that where we come from. So I'm represented by the yellow dot here. This is Hong Kong, and this is part of China. And I will tell you a little bit about my background, and the red dot represents Poornima. where she is in India. So a little bit about my own background. I was born in Hong Kong, and I had my education in psychotherapy. I did my PhD in the United States. So now I'm back in Hong Kong. So there is a lot of transitions, going to a different country to learn about psychotherapy, and then now bringing that knowledge to share it with my students in the local context in Asia. And so I will pass the time to Poornima to talk a little bit about her background and her experiences.
Hello, everyone. So I work as a psychotherapist, a supervisor, and a researcher in Bangalore, in India. And at the same institute where I trained, I've always lived in India, but in different parts of India, which carries its own diversity. Um, I'll tell you a little bit about the place I work. So it's the largest center in India for mental health education and care across both inpatient and outpatient settings. And as a government-supported hospital, we provide care for people who come from across the country, who speak different languages, and who have varied access to experiences and resources. And we also provide free services for those who are below the poverty line. Um, India, of course, I think it's like a multiple cultures within cultures of the same country. It's a country that's marked by a history of colonization by the British, immense diversity. We have 22 official languages that are recognized in our constitution. Over 60% of our population lives in villages, and we have a rich tapestry of religions, ethnicities, and traditions. A fairly large youth population. And of course, like everywhere in the world, we're also buffeted by strong forces of globalization and change. So this is really to give you an idea where I come from and the kind of work that I do.
So I also can mention a little bit about my setting. I work in the Faculty of Education. So I work with a lot of school social workers and school teachers to help them gain some counseling skills as they do some supportive work for their students. Some of them are also thinking about changing careers to become full-time counselors. And so this is the context that I work in. Okay, so now moving on to the next slide, Poornima is going to talk a little bit about the context of our talk today.
So, when we began speaking about culture, we sort of realized that culture is really the sea that you're swimming in. So it's a sort of very tacit or implicit knowledge. And I think sometimes it's unspoken or even unnoticed until one comes in contact with a culture that's quite different. And that's when you begin to realize the diversity of cultural frameworks. So today we're going to really use a more constructivist view of culture, looking at culture as dynamic, as context dependent, as shaped by lived experience, by power relations and intersections in society, and really not as something that is very fixed, very homogeneous, or which is very rooted in a sort of static tradition or identity. So clearly, in the time that we have today, we're not going to speak for Asia. I don't think I can speak for India. And I also think that we don't want to be trapped in this East versus West sort of comparison, because that I don't think is a very meaningful way to approach this discussion. And we also recognize, like I said, there are cultures within cultures across intersections of social locations, be it gender, class, caste, literacy levels, and all of the different dimensions in society. And those are cultures in themselves. Perhaps something that we won't have time to delve into it quite so deeply. During the time that we have, we're going to try and make some of this implicit knowledge that we are carrying to make it more explicit, speak to the diversity of experiences and responses across some Asian cultures and contexts. And at the same time, we want to put it out there that every therapy encounter is a cross-cultural encounter. And we want to keep that in mind, that this is a space where we navigate and celebrate, I hope, both differences and sameness. And so that's really the philosophy with which we'd like to approach the rest of our time together.
Yeah. So I'm going to talk a little bit about the work that we do in SPR Asia and why we talk about this organization is also because we drew a lot of inspiration for today's talk from this group. It is actually the latest area affiliate group for SPR. We were developed we were formed in December 2022. And our aim is really to promote psychotherapy research in Asia, foster collaboration among researchers in Asian countries, and also increase mutually beneficial interaction and collaboration between practitioners and researchers. So in the Asian context, may not be as many psychotherapy researchers compared to Europe or North America or South America. But when we hold our events online, there were a lot of practitioners who are actually interested in doing more research in this area. And so we really hope that as an organization, SPR Asia can promote this collaboration and interaction between practitioners and researchers so that we can grow and together, both in practice and research. And also to enhance mentorship between trainee and also early career members with more experienced members. And finally, to encourage our local researchers and clinicians to participate in the international SPR and chapter conferences so that the voices from different areas of the world can be heard in the international SPR conference. And so next, I'm going to share a little bit about our work so far. This is one of the webinars that we have held. And this was done in November last year, and it was a roundtable on cultural adaptation of psychotherapy. So in that roundtable, we talked a lot about how we adapt what we learned from the Western textbook in the Asian context, but more, I think, in that roundtable, what really came through was that we should not be just thinking about cultural adaptation of what is conducted in the West, but also how there is a long tradition, a lot of different healing practices in the Asian regions. They may not be known to psychotherapy researchers. There may not be studies done on them, but we should not feel that those are less valid practices, and we should also be more aware of those practices instead and see what we can gain from there and to have a more richer repertoire in terms of therapeutic intervention. And then we also had our next webinar, which is another roundtable, and it was talking about the empathy expressions across different cultures. And in that seminar, we focused on, the discussion is around what is culturally appropriate ways to express empathy. And we are going to talk a bit more today about the different themes that come up in terms of, how we express care to another person. Do we use it verbally? What kind of language we use or nonverbal communication we use to express empathy? And so we are going to focus a little bit more on that from this webinar's discussion, okay? Or the roundtable's discussion.
Harold,
yes.
I'm so sorry for stopping you. I just want to stop you for a brief minute. It
Sure.
seems some people in the chat hear you with a bit of an echo. I just wanted to see whether you could maybe sit a bit closer or if you have maybe a different microphone that we could switch to.
Okay, sure. Let me maybe get out and come back in. Maybe that will help.
Okay.
Hello. Is this better? Or still echoed?
For me, it seems a bit better. Does anyone feel otherwise?
It is better? Okay, sorry about that.
Okay, perfect. Thank you so much. Please continue.
Yeah. Okay, so next we're going to talk about stigma of help seeking. So today, even though we are trying to talk about therapeutic relationship in the room, but there's actually a lot of people who, because of stigma or other reasons, may not be getting into the therapeutic relationship. So we want to highlight that, and as psychotherapists, we should also be mindful about, even when people come into the therapy room, it doesn't mean that there's no more stigma because they managed to come into the therapy room. And that really brings up, how we engage the clients and how we want to relate to our clients. So a little bit of the definition. First, we want to talk about the public stigma, and this is really the external form of stigma that denotes perception held by society that individuals are undesirable or unacceptable if they were to seek help. So this is the feeling that, okay, people tend to like less those who are receiving help. Whereas self-stigma refers to the perception held by individuals that they are undesirable or socially unacceptable if they were to seek help. So example item would be, I would feel inadequate if I went to a therapist for help. So comparing the two types of stigma, those are really highly correlated, but you may want to pay attention to statements about, self-beating statements. So self-stigma has a higher relationship or stronger relationship with help-seeking attitude and help-seeking intention. So I'm going to show you a study done in almost 10 years ago. It was a comparison study across 10 different countries and samples. I highlighted 4 areas that are from Asia: Hong Kong, Taiwan, Turkey, and UAE. And so as you can see here, these are all college students, about over 300 students from each country or region. And we see here is that there's a percentage of receiving help is quite different. As you can see here, Hong Kong, just 10% people are receiving help. UAE is about 6% who reported receiving help, as opposed to US, 23%, Australia, 44%. So this is sort of a map, as you can see, if this stigma and help seeking and how commonly do people go to seek help. And if we look at the stigma, level of stigma, the higher scores represent higher level of stigma, public stigma and self-stigma. Here we can see that Hong Kong has really high self-stigma. It's 28, score of 28 as opposed to Romania, say 23, or Turkey, 22. So this is one of the contributing factors to why people are not going to get help. And correspondingly, the attitude, the lower the score, the worse the attitude. You can see here, Hong Kong is one of the lowest compared to Taiwan or Turkey. So this is just a little bit of the context, and we want to be mindful about how we relate to our patients. So I'm going to turn the time to Poornima.
All right. So Harold, thank you for speaking about stigma and how that really impacts the pathway to help seeking. And we see that clearly in India as well. A recently conducted national mental health survey showed us that the treatment gap is very, very high. There's 70 to 92% of people who need help never actually get to help at all. So it's not just like a delay, but they might never reach the resource. At the same time, I don't think we can say it's all because of stigma. It's pretty much a complex interplay between stigma, unequal access to the really limited mental health resources, and also culturally rooted explanatory models of distress. So in many communities in India, deeply held sort of beliefs about faith healing, those are strong influences on help-seeking behaviors. So quite often religious sites or shrines become the first and sometimes the only point of support. At many points, let's say they can be helpful, but as we can see in this particular image, sometimes they can be coercive spaces as well. So let's look at what we can do. So there have been a number of innovative initiatives to sort of bridge this mental health gap and to establish an alliance of sorts. So I think if we're really looking at building an alliance, we need to sort of not start in our clinics when the person enters the therapy room, but really go into the community and meet people where they are. And also maybe to recognize there are many therapeutic relationships that are outside the therapy room. So I'm going to focus a little bit on one innovative project, which is called the Dawa Dua project, which is a combination of Dawa as in medicine / therapy, and Dua, which is prayers. So it's sort of, these are projects that engage faith healers along with mental health practitioners in close proximity or within the sites, the religious sites itself. So it sort of fosters a sense of trust and connection where formal mental health care I might have been viewed with skepticism earlier. So we do have a number of community-based initiatives, whether it's anti-stigma, whether it's training frontline health workers to improve mental health literacy. So it's really a sort of a multi-pronged sort of initiative. In India, I think one of the really dramatic shifts has been post-COVID. There are many more conversations about mental health, and I think that somewhere there are new entry points for care, and that has been really something very, very prominent. Ultimately, really what I want to emphasize is that building a therapeutic alliance, which is what we're talking about today, begins with connection. And that connection can take place in clinics, in homes, in temples, in dargahs, or across screens. And I think that kind of looking at fostering connection is really important, rather than waiting in the therapy room and then trying to change someone's way of thinking. And I think there's huge potential to do more of that. Sort of looking within, if I were to say, this looks like everyone in India is seeking help through religious or spiritual practices. That is absolutely not the case. I think India's cultural diversity and rapid social change, what does it require us to be as therapists? I would say it requires us to be like chameleons. We have to be very flexible and very sensitive to the different backgrounds, the different expectations, the different preferences, and the worldviews that people come with. And until we are able to flexibly adapt to that, it becomes very difficult to build a connection. Now, while most therapists practice in urban settings, you're likely, depending on the place you work in, you're likely to see a diverse group of people. So from my own practice, for example, in my first appointment, someone may walk in coming prepared to discuss the latest meta-analytic review on treatments for depression. And the next person could be someone who has a worldview which is very deeply rooted in traditional beliefs or spiritual explanation. So clearly, it requires a lot of shift on the part of the therapist and a lot of self-reflection in terms of your own positioning. So when we work in culturally diverse settings, I think what's perhaps most important is that for us to recognize that people actually have the capacity to hold multiple explanatory models at the same time. So if you're not looking to challenge one and then start operating from our, whatever we think the therapy model is, then it becomes much easier, and you're able to sort of respond to metaphors and practices that are both personally and culturally relevant for the person, and create a space for therapy and for the relationship.
Let me unmute myself. Okay, this is the next part about construction of the therapeutic relationship. First of all, it's really about the hierarchical relationship that we often see in the Asian culture, and that starts from addressing the therapist. So, for example, a lot of clients will use honorifics, so they call us doctors or Mr. or Miss, and versus first name. I think in where I was trained in the US during internship, I usually use my first name, and clients feel very comfortable using my first name. Whereas coming back to Hong Kong, when I see clients, they would have a difficult time calling by my first name. Maybe there's a distance that they would prefer in terms of using your honorific or how they address us. This is quite similar across different cultures within Asia. So we hear it from Japan, we heard it from Korea. I think Poornima talked about it in India as well. And it is not only between clients and therapists, but also between students and teachers. I think they would also have a hard time calling us differently. I remember having this PhD student in every email, I would sign up as Harold, but I would still get back, Professor Chui, and this is very ingrained in the student's mind, and it is, even though there's some encouragement or invitation, I think they feel more comfortable to maintain this distance. And then secondly, we talked a little bit about how comfortable we are in terms of expressing or articulating closeness or verbalizing our closeness to other people. And this could be related to hierarchy in relationship, but it could also be, whether interpersonal relationships are defined or operate differently in different cultures. So, for example, in the context that where I was trained in, I was taught, immediacy statements in interpersonal therapy. So, for example, I may say, I felt closer to you, the client, when you disclose this. And when I try to use that and in Hong Kong and tell my students, perhaps you can say this, but they had such high resistance. They say, no, this is too mushy, too touchy-feely, and this is not comfortable at all. And I know it's cultural when it's the whole class who had this, resistance. It's not just one or two students. So instead, then I asked them, how should I use, this kind of intervention in a culturally appropriate way? And, they came up with, perhaps we can mention about the distance between two people becoming, decreased as the client is close. So I think this is a way of how language work in our when we think about working cross-cultural. Also, in terms of extending from what we are talking about in terms of language, I did a study on formality of language in psychotherapy, and this was done in Hong Kong. And this what we looked at was what we call discourse particles. So these are words that are added at the end of sentences or at the end of words or phrases to signal attitude or emotion or intention. And they are similar to intonations, for example, in English. And so, for example, in Cantonese, when someone asks me, how are you? And I would reply, okay. And I will add different discourse particles at the end. So if I say okay, ge, it means that I am just so, okay? Whereas if I say okay, okay, that means that I'm quite upbeat. Whereas the last one, okay la, and that means that I got better from a pretty bad place. So it is all, signaling a lot of different meanings, and you need to know, be very familiar with the language in order to appreciate the hidden meaning of these signals. So in the research that I was doing, we were looking at, the more particles that people use, it signals that the language is more casual. Whereas if they use fewer particles, it means that the conversation is more formal. And an example is the news anchors. People you see on TV who's reporting the news, they would not use any discourse particles at all. And this is formal language. Okay, so we want to see the relationship between the therapist's use of discourse particles and their perception and the observer's perception of the therapist's empathy. And what we found was quite interesting. So when therapists, when we are looking at therapists' absolute formality or their percentage of particular use, this was not related to the perception of the observer's perception of the therapist's empathy. So it doesn't mean that the more formal the therapist is better, or more casual the therapist is better. But what is really interesting is that we found that relative formality matters. So therapists are seen as more empathic if they are slightly more formal compared to their clients. If they speak in a slightly more formal language in terms of using fewer particles. And so we assume that this is part of the cultural script. So these observers come from this culture, and when they see therapy that the interaction in this particular way, more formal therapists with more casual clients, they see more of this as empathic encounter. So there was one exception. So for example, some clients who spoke very formally with very few particles, in that case, therapist casualness, using more particles, that was seen as an empathic gesture, a way of expressing empathy. And this could indicate some efforts on the part of the therapist that they were trying to help the clients to ease into the therapeutic relationship. So next time when you work with clients cross-culturally, perhaps you can think about the level of comfort in terms of the casualness versus formality in the room, in the conversation. So next, we want to talk a little bit about role expectations. It is the balancing between not knowing and knowing. So not knowing is something that we emphasize a lot in the humanistic orientation or client-centered orientation. We want to emphasize that clients are their own experts in their lives. But in culture, in a hierarchical relationship that characterize our culture in Asia, some of the knowing is important because they look to therapists to be the experts. So for example, in another study that we did on therapist directives in mainland China, what we found was that the use of directives actually strengthened the working alliance between therapists and clients, and that predicted treatment outcome. And even more interestingly is that there was the number of directives and the acceptability of the directives that were more important than the implementation of the directives. So it doesn't matter whether the client is actually practicing what you tell them to do, but actually it's the giving them in a way that they feel it is acceptable that strengthen the relationship and then contribute to the outcome. So we can see in this context, perhaps giving directives is a way for therapists to demonstrate some expertise, or is a way to show care to the client as well. But we want to emphasize that we don't want to assume that clients do not want to have a say just because they are Asians. Okay, so we did another study on unwanted experiences for clients in Hong Kong. So we interviewed 25 clients, and one message that is that they actually have some ideas what they want or don't want in therapy, but they did not realize that they could talk about these unpleasant experiences in the therapy session. So one of the implications is that the therapist perhaps need to proactively check in with the clients on the thoughts and feelings that they feel towards therapy. And of course, this is in no way unique about Asia, but I think in the cultural context of the hierarchical relationships, this becomes even more important. And finally, in terms of role expectations, some of the clients, because they may not have had experiences in therapy, there could be some benefits in giving them more information about what is expected in therapy sessions, the rationale for doing that. For example, in the helping skills model, Korean therapists talk about introducing a pre-exploration stage to their clients to let them know that, okay, we are going to ask open questions about feelings, open questions about thoughts. So we are not trying to make things difficult for you, but this is how it works to open up the session to help us to understand what you're thinking. So having this, information even before therapy, before the start of the interaction, can really help clients, especially if they're unfamiliar with the therapeutic context.
So much of what you said, Harold, really resonated, with what happens in the Indian context as well. And quite a while ago, the therapeutic relationship in India was spoken about it as as one between a guru and the disciple. And you can always see that there would be a difference in terms of power. There would be a certain distance. But really, this is conceptualized almost as the therapist being part of a larger joint family like we have in India. So as a benevolent elder in the family who might be guiding you, who might be sharing some options and really has your best interests at heart. So it's not really like a controlling directive figure in that sense. But however, with a relationship construed like this, it's possible that, the patient or family members may have questions that are not voiced or things that are not shared, and they might be seeking a lot of guidance. I absolutely agree with Harold when he said that perhaps this is something one needs to ease into. So you provide options, you invite the person to speak. There's perhaps a little bit of an induction phase, because there's always a danger that you hide behind the curtain of culture and conveniently become very directive because you know what to say. That's what the culture expects. So I think that's a challenge for all of us therapists, not to hide behind that, but to sort of go up front and negotiate a potential power imbalance in the relationship and try to build something that's a more collaborative interaction, one in which the person can ask questions, debate, disagree with the practitioner. I know so many of us as therapists are quite happy when our clients are a little bit angry with us. It's a sign of progress in many ways. And I can see a lot of shift in terms of many of my younger clients. They are definitely looking for something much more equitable. They are not going to buy this guru chela relationship model at all. But it's quite interesting. Even my younger clients will not call me by my first name. They might call me ma'am, or they might call me doctor, so and so, or they have different ways of addressing me. So they'll address me in the more formal way, but nothing else in the interaction will be quite so unbalanced. Otherwise, the relationship is far more equitable in the expectation. So it calls for a lot of navigation, I think, on our part. Talking a little bit about language, Harold, what you were sharing, I was thinking to myself that even though there is this power imbalance in the room, and as a therapist, I might carry much more power and a certain expectation. But if I have a client who's a little bit older, I will make sure to adjust my language, that I use more formal language. My body language is also a lot more respectful. I'm very different like that. So I'm also adhering to a certain cultural framework that there is. So there's the therapy relationship, and then there are all of the other ways that relationships have to be navigated within our context, and all of those have to come together in rather complex sort of ways. I did want to share a little tiny snapshot from some research we did a long time ago as part of the SPR Collaborative Research Network, where we examined the personal and professional development of 245 therapists in India across 21 states. And I'm just showing you a little bit, a set of questions on the therapy relationship, where therapists respond to how often their clients engage in a particular behavior from on a 5-point response scale. So you see that, if you look at the responses marked in red, there's a fairly significant proportion of therapists who say that it's extremely or very likely that their clients idealize them, expected more guidance, or asked them a lot of personal questions, right? But at the same time, let's look at the next two items. Not as many therapists see their clients as redefining boundaries or having continued dependency on them. So this is a very interesting pattern to reflect on, that the initial few questions seem to suggest a lot of shifting of the boundaries, a lot of idealization, a lot of inequity in the relationship, and perhaps something that might lead to dependency, but it's not exactly playing out like that. So I think this is very interesting to understand in the cultural context, that even if there is a certain amount of idealization or certain amount of expectation of guidance, it doesn't really mean. So there's a way to navigate the boundaries and the relationship, even with these slightly different expectations that might play out. And then I really wanted to speak about something that I've always thought about. It's a very interesting paradox in Indian therapy spaces. There's a hierarchy. So the therapist is perceived through a hierarchical lens as someone who's knowledgeable, who's more powerful, who should offer some guidance. At the same time, psychotherapy unfolds in it's a relational culture. So we also see there's a lot of value for emotional closeness, for familiarity, for interconnectedness. So the client simultaneously desires more intimacy. So there's something that creates distance, but there's also an equal pull towards intimacy. So a client may sometimes refer to me saying that you're like my akka or my elder sister, or may ask me right off the bat. This is very common. I'm sure any of the therapists from India who are here in the space today will say that being asked personal questions like, are you married? Especially for women, very early on, maybe first time meeting, where do you belong? What's the common questions, what's your native place? So wanting to situate you somewhere, asking lots of these questions. It's very, very common, and trainees get thrown off because, their textbooks are telling them that this is not really okay to respond to, but there is that need to connect. So I think it's quite paradoxical that they are simultaneously seeking some sort of reassuring distance, but at the same time seeking relational proximity. And this is really something for therapists to navigate. The goal can't be either to erase that hierarchy or to dissolve that closeness, but like to hold both of these with some degree of awareness, and sort of work with it and understand where it's coming from, and even discuss this with clients at the appropriate time and in the appropriate way. So I think this paradox is something that I really wanted to share today.
And it's very interesting when you say, where is native for you? And if you ask that, where you come from in the US, people take offense, as if I'm not
Right.
American, or you are not because you look, Asian, and you're not, you're not from the United States. So it's quite, the same question can trigger such different responses.
Right, right. And so really, if we've spoken about all this, what does this mean for the frame of therapy? What do we see as a boundary transgression? And I think that in some of the research that I've done, there's a lot of concern about the whole process of gift giving. Because once again, one has learned about this in a particular way, and the need to understand and interpret what the meaning behind your client offering a gift. But sometimes it can be within the Indian cultural context. Of course, there can be many reasons and ways in which gifts are presented, but sometimes a client may present a gift almost as they're a family elder and say, you're like my son or my daughter, or it is around certain festivals. So it's quite customary sometimes to do that. And sometimes, of course, it can have the very many more complicated meanings as well. And I think that perhaps the skill one, I'm not saying that that means we have to accept all gifts. Of course not. You have to go through the same ethical decision-making process and things like that. But I think it's wise to anticipate that this is going to happen rather than be thrown off guard and then, look at it as something that's going to disturb the alliance and, shatter the frame of therapy or whatever it might be, to really look at it in context. And one of the things I think that in India, at least for myself, I think the skill that one needs to learn is how to refuse the gift when it needs to be refused, but in a very respectful way so that it is not insulting for the person. So I think that is really, so it's gentle, it's assertive, it has to be very culturally sensitive. And I think that's really the skill to learn. So when Harold and I were speaking about this, I was remembering very long ago when I was a trainee. I saw this woman and her mother, and they were really from a very economically disadvantaged background. And I'd spent more than a month seeing them while they were in the inpatient setting, and they were due to go, and I went to say goodbye to them. And just as I was leaving, the mother very discreetly tucked a 50 rupee note in my palm. Just while saying bye, she held onto my hand and kind of just inserted it in. Now that's less than $1. It's maybe like half $1, but for someone like her, this is a tradition that when you go to meet an elder or an elder comes to meet you, they can give you a little money and say, buy some sweets, which is what she said to me. Buy yourself some sweets. Well, I didn't take the money from her, but it was very important that I not take it in the best way possible. That I accept the meaning without necessarily accepting the money. So I was speaking to Harold about this, and then he had a very different sort of experience to share.
I was in the US and this was practicum. And I think the client gave me an extra $5. And that was like, oh, and I asked him why immediately. I thought he, forgot that he was paying 20 instead of 25. And so he said, oh, I think we did well today. And so this is such a clinical question, right? Okay, you feel that we did productive work and you want to tip me. And so this is something that it became more of a therapeutic or clinical discussion. So I think this was very important um, to be explored, and a supervisor and I, use supervision to talk about how to work with the clients on this, what are some of the internal dynamics. So it is, similar situation, money, but it means so different. So many. I mean, it meant such a different thing across culture. Yeah. So now we can move on to talk about emotional exploration, and this is also very important. And I think this was something that came up a lot in our roundtable discussion. Is that in a lot of Asian cultures and East Asian cultures, for example, Japan, Korea, China, there's a lot of indirect discussion of emotions. So, for example, a lot of emotions are not talked about in terms of emotional words. So people may not be using, our emotion lexicon to describe their emotions, but they will talk about how their bodies are feeling. They may feel tension, they may feel giddy, they may feel this pain and that pain. They can also use to talk about different behaviors. For example, they say, I shut myself in the room the whole day, I was banging on the wall. And when we use, when we try to ask them what it feels, what do you mean by that? What are the underlying feelings? There's some hesitance to use, emotions to label them, and they tell you more details of the behaviors and more of the body sensations. And we thought that this is one maybe indirect way of disclosing their emotional states to the therapists. And so we need to be aware of that. And there's also in the literature saying that, Korean therapists may express empathy and genuineness more through nonverbal communication than verbal channels. So it could be, eye contact, a lot of the, body gestures, body movements and gestures that show care to a client. And then we also talked a little bit about the use of subjects. So and it was fascinating. And I think Poornima and I were not aware of this in Japan and Taiwan. And so the Japanese, I think Shigeru was in the roundtable, and they talked about how, when they describe intense emotions, for example, anger, they would not say, I am angry. They would omit I, they would say angry, or even the lesser version or less intense version. So they may say upset instead of angry or I am angry. And in Taiwan, it's similar. They talked about how they would not say I am angry, but they would say, you are angry when this and this and this happened. It's almost like putting some distance. It's a culturally appropriate way, and we connected this perhaps to confusion value of emotional moderation and control. So if we force somebody, or if someone were to own the intense negative emotions and say I am angry, they may be they may feel that this is immaturity or a less sophisticated way of being, and they may not feel comfortable doing this, especially in front of an authority figure like a therapist. So that was really interesting and fascinating in terms of how how we operate. I remember in learning therapy in the US, we try to help clients to own some of these feelings. Say I feel this, I feel that, but or even use confrontation or challenge the clients if they are not using the subject I. So I thought this was really a prime example of how we need to be sensitive to the cultures, the sea of culture, as Poornima talked about. And so rather than individual catharsis, and when we are trying to explore emotions and say this is a good thing, maybe we can frame the emotional discussion as something that, helps to build connections, help to increase mutual understanding and group harmony. And then there's also emotional expressions, and this happened really early. There were studies that were conducted, cross-cultural studies, and looking at preschoolers who, receive a disappointing gift, and they would, even though it was a disappointing, not something that they want, they would display fewer negative emotions and more neutral expressions compared to American preschoolers. So we are saying that this is something that was really ingrained, started to learn about this at home when we are really young at school. So we need to be aware that, okay, it doesn't mean that people are not feeling things, but they just may not be showing it on their face as much. In terms of the emotional experience, there's some studies that show that American undergraduates or English-speaking therapists would tend to report higher intensity of emotions. And again, in the literature, they were saying that maybe it's not the real intensity, but what they feel okay to be reporting on this survey. All right. And there are some studies that show that the comfort level with low arousal emotions, for example, calm and serenity, that there's a preference for people from the East to experience these rather than high arousal, for example, excitement, where people may feel more comfortable or want to experience in places outside the East. So we want to pay attention to the emotional tone of therapy sessions if something's become very intense in the room, and how we navigate that and make sure to check in with the client, how they feel, especially towards the end of the hour. We don't want to leave them feeling really exposed or unwrapped if they tend towards to emotional moderation and control. And when we talk about experience, we also talk about regulation strategies. So in some studies, in meta-analytic studies across different emotional regulation strategies, they found that East Asians may prefer or use more suppression, which is the inhibition of outward emotional expression, and avoidance, which is trying to not accept or experience any distressing thoughts or memories and anything that trigger emotions. And there's some literature showing that Chinese men may use more disengagement. So I think we want to be respectful and mindful of the need to avoid overly intense emotions, and respect that some people may use more distraction strategies sometimes. And this is not unique to cultures. I think we want to respect people's defenses, and examine our own biases. Okay.
Thanks. So, as therapists, I think we love words, we love naming things. And over time, I think I've become more and more aware of, looking at embodied experiences. And so I really wanted to bring some focus to the body as a site of emotions. This is particularly, I think, relevant in India as well, because quite often somatic experiences are the more legitimized and understandable outlets for distress, particularly in contexts and for people where direct emotional articulation is constrained. It's difficult to talk about conflict or loss or desire or whatever it might be. And so, for example, at the hospital where I work, often, not only women, but often women, sometimes at certain intersections of class and or religion, they present to clinics with a lot of diffuse pain. And there's a very typical phrase of a certain pulling sensation in the arms and legs, which tends to persist. And they would have gone to all sorts of doctors before, landing up here. And this is something that quite early in our training, we are told to recognize this as a form of psychic distress, and sometimes as depression, which is not, it is not easily possible to say I'm sad or I'm trapped or I'm frustrated or I'm whatever it might be, but it's easier to express the pain in this way. So I think if you're going to have a culturally informed therapeutic approach, then you have to recognize more and more, and this has been a learning for me as well, that the body is a meaningful sort of mode of narration, and sometimes the silences, the symptoms, the sensations, they all like express certain emotions which cannot otherwise be sort of spoken. So sometimes we may have to pause. It's while emotion naming is important, but it may be a process, and it may be something that you need to work. I mean, after all, this is also a communicative act. So we might have to adjust our response to that and not always frame it in the ways that we've sort of studied and which we're more comfortable with. So I also wanted to talk about another aspect, which is the body as a site of a resistance. So sometimes when you don't have any other way to speak about what you're feeling and you don't have any other escape, then sometimes this expression of psychological distress also brings relief. The relief may be temporary. So I'm going to say that we see a lot of people with, of course, dissociation, also trance, possession. These are all things that we see. And I'm just going to draw your attention to a movie, actually, by an Indian filmmaker who's based in New York. I had a very interesting panel discussion with her around the movie, and I found so much resonance between that and what we see in our clinics. So, Eyes of Stone, it's a film about spirit possession, faith, and healing. It's in a particular temple in rural India. So, what the filmmaker does is that she explores a young woman's journey of different experiences. Shanta is a 19-year-old woman from a village. She was married at the age of 10, and she is mother to two surviving children at the time. And she's constantly having experiences of headaches, fevers, fatigue, a sense of disconnection, and then states of possession and trance. And when she's possessed by this evil spirit or darken, it sort of gives her the permission to be violent, to be angry, to say all the things that she is missing and that she needs. And to also move from her husband's home to her natal home and just rest and then go to the temple for relief. So I think in this way, we also learn that often it's the dispossessed who are possessed. And it is this time that it's the body then becomes a site of resistance, a way to speak about what otherwise will remain unspoken. So I think that this, of course, is a more dramatic example, but I think many of our clients with dissociative manifestations, I think this is a really useful sort of language to look at. And to see that if people are finding it difficult to express in this way, then we need to also have slightly more indirect or other ways to meet them at their communication rather than in the very traditional ways that we tend to sort of use. So I think emotional expression and responding to that. The third thing that I wanted to speak about is, so if you look at this poster, it's a very retro sort of poster. And when I was growing up, we used to get this at the stationery shops. It used to tell you this is about an ideal boy. There's also one about an ideal girl who, of course, has more to do. So the ideal boy does all the right things, is very obedient, salutes the parents, does all the right things, is respectful, lots of relational harmony, takes part in various social activities, things like that. And if you can notice, there's no loud running around. Everything is quite regulated. So I think even what Harold was saying, emotional restraint as a marker of maturity. And sort of this poster really exemplifies the emotion socialization that happens. And also within families, age and gender makes a difference. Of course, the voice and space is less for girls and women, and less according to age as well. If you're younger, you automatically have much less say, and you must listen to the older person, and you cannot express everything that you wish to express. So how we see this operating in the therapy setting is that before asking about family relationships, communication, things like that, there is often a need to provide permission. Often it's quite implicit, but sometimes even explicit, so that the clients feel they can express negative feelings, particularly those that involve family members. I think that sometimes we do it so automatically that uh, I mean, it's only in preparing for today's talk that I realized, oh, this is something that I kind of do almost all the time, uh, to different degrees, depending on how much needed, to sort of give that space to say this is something that can be expressed and it's okay to express it. Yeah.
So we're trying to make culture implicit to explicit when we give a webinar. So finally, we can talk a little bit about training and supervision. So what we spoke so far about the hierarchical relationship and role expectations from the therapy room really translates into the supervisory relationship as well. So for example, there's this hierarchy in the teacher-student relationship. So a lot of students may see supervisors as high-ranking authority figures, and with that, it means that they may have more difficulty expressing or talking about the thoughts and emotions in supervision. For example, it may be very difficult to disagree with the supervisor, or they may be hesitant to bring up things that they are not so sure about, especially if they think that they have made a mistake and they feel that they want to protect this image from the supervisors and want to make sure that they do not rock the boat, so to speak, or make the relationship a little difficult because of their performance in the therapy room. So there may also be some role expectations. So trainees may expect concrete answers and suggestions and advice from supervisors. For example, there's this if they grew up in a culture. So for example, in Hong Kong, there's a lot of culture of spoon feeding from the teacher to the students. Then they may expect this to operate in the supervision relationship as well, that they come to supervisors for answers. So they may prepare a lot of questions to the supervisors and expect answers. Whereas, when we train in the West, we always talk about the process. We want to be collaborative, think about the answers together. So there may be some expectations that we need to manage and also to talk openly about at the beginning of the supervisory relationship. And supervisors in Korea, on the other hand, may be more likely to adopt a structured and solution-focused approach. So what we want to bring up is that supervisors may still invite supervisees to talk about their discomforts or needs in an active and sensitive way. And this really, the burden may come from, will be on the supervisors to take this lead. There is also some encouragement to introduce self-reflection early in the therapy training, especially if there's not a lot of space in the past education experiences to do a lot of self-reflection, to do more collaborative conversation with teachers. Then we may want to provide some framework how to do this.
So just to continue with talking about supervision, though I agree, that there is a certain expectation of more direction and, guidance from the supervisor. But I do see an encouraging shift. Quite recently, some research that we did, in the qualitative inquiry, we found that, so we did this research with the 94 trainees from across 8 psychotherapy training centers in India. And we found that there's a lot of sort of expressed need from the trainees that they're looking for supervisory relationships that are more collaborative, more emotionally holding, and more supportive of reflective sort of person of the therapist work. So I think that there is a sort of shift. And the way we do it sort of where I work is what we try to do is we have these small supervisory groups where we often so it's a bunch of like trainees and supervisors at different levels. So there's some doctoral students, there are other clinical psychologists, there's some of us who are in the faculty. And so we try to begin with a lot of self-disclosure from the supervisors about times that we've felt stuck or in the process, and somehow that really opens things up. So I'm actually quite positive about a lot of change in the supervisee dynamic in our context. And I think that this maybe means that we need to have much more focus on supervisor development and training, to focus on these aspects. And finally, I just wanted to bring in this idea of what we've talked about today. I think it's a broad brush. And what we've missed talking about is really much deeper reflections of power and positionality in the therapeutic relationship. Also, to use an intersectional lens to focus more on the role of embodied forms of relating and communicating. So I think there's scope for a much deeper dive, so to speak, for all of us. And what is really important, I think, is that if we're going to look at how we change training or how we enhance training in terms of building the alliance, then I think we need to look at very key concepts such as, let's say, attachment and mentalizing. These are very central to alliance building, yet they are typically framed through very Eurocentric developmental models. So, I mean, for example, how does one understand what is dependency? What is insecure attachment? What are the appropriate caregiving practices? I think that there would be quite a lot of differences across cultural contexts. So how are we coding and interpreting mentalizing? Are we sensitive or attentive enough to the embodied or non-verbal or culturally specific forms of mentalizing that might not align with dominant frameworks? So I think some sort of critical engagement with these kind of knowledge frameworks and resources that we tend to use in training quite uncritically. I think there's a wealth of knowledge in all cultural contexts where psychotherapy is practiced. But I think one of the gaps is that there's less publishing and conversation. Like today, we have spoken and shared, and maybe there will be more opportunities in the future, and we learn from each other. But there's very little publishing and very few publishing avenues also. So, how are we going to disseminate this knowledge and how are we going to integrate it into training context? I really think this is something for us to move forward. At the same time, let's not dismiss the value of universals altogether. I mean, concepts like safety, trust, connection, they may manifest differently across cultures and contexts, but they are like absolutely fundamental to therapeutic engagement. So I don't think that everything needs to be questioned, but some sort of deeper reflection on all of these aspects, I think, would take us a long way.
So we have come towards the end of our webinar, and each of us came up with one question that keep coming up in our minds. So for mine is there's a lot of emphasis on emotional exploration during training and practice, and it really reflects the theoretical orientation that I was trained in, and also my training background. So what if suppression and avoidance work just as well? So I talk to my friends and they seem to be doing fine and playing with their IG and have all kinds of material things and engage in different ways, and they seem pretty happy to me, and I think they may think that I'm thinking too much sometimes. So I think what is what do therapists bring to the room? It's really important that to be aware of some of our own biases, and there could be other ways of other paths towards well-being. So that was one for me.
I really loved your reflective question, Harold. But I think I was left thinking that I know so little, and how do we even begin to expand this understanding of the therapeutic alliance and building connection across diverse Asian contexts? I think there's so much for us to do, so much for us to learn and find avenues, because not all the time will we meet in psychotherapy conferences. There have to be other spaces that we create to sort of engage with each other. And I'm really hoping that, though some of those doors will open for me at least.
Yep, so that comes to the end of our webinar presentation. So we would like to open the floor for discussion and comments and questions. Thank you. So I will stop sharing the slides. So feel free to type in the chat box or you may open your mic and a little discussion. And Denise.
Hello.
Hi.
Good to see you, Harold and
See you
Poornima,
too.
very close friends. No, I was wondering, I loved your presentation, of course, and I think we must go on in these sort of detailed jewelry, I would say, presentations in the sense of exploring not the gross matter of psychotherapy, but this real therapy in real persons and real contexts. But I was wondering, because one thinks, what is the best way to understand and adapt participatory research, certainly. But I was wondering, coming from Latin America, which is, and it's Latin, Harold, not South America, it's Latin America.
Sorry.
Because then you're excluding Central America and Mexico. So it's Latin America, the chapter is Latin America. But I was wondering how, I know in Latin America, participatory research is very well accepted. And in fact, the action research method is very successful because the tradition is very participative communities. For example, in indigenous peoples, it's a group of elderly people from the community who take the decisions in the town, for example. But I don't know in Asia whether that would be accepted, because I know very little. I have not been to Asia, but I really can understand this distance. So would somebody in the position of a common person accept being part as a co-researcher? So that's my comment and my question. And thank you. It's been a wonderful presentation.
Thank you. So I know action research is definitely taught in my school. So there's a class on action research, and but I'm not as familiar about it in the psychotherapy setting, and how people may do it in terms of mental health. There probably is, but I'm not as familiar with this line of research.
So if I can share a little bit about India, and there could be other people in the room today who can speak to it a little bit more. I do think that this is happening. It is accepted. There's a lot of community-based work, but a lot of that is done by non-governmental organizations, not so much coming from the very traditional mental health care settings or hospitals or educational spaces. But what we do find is there are a lot of organizations. There's an organization called Sangat, which is doing some excellent work. There are a lot of people doing community-based work, and I can see that the value of lived experience is gaining a lot of conversation in India. We have a new organization called the India Mental Health Alliance, and they center all their work around lived experience. So I think that if you were to ask me this question again in maybe just a couple of years, I might have a slightly different
Better
answer
answer.
to give.
Okay.
Yes.
Because you introduced this method which integrates religion and medicine. And in fact, in Brazil, for example, the most successful psychiatric hospitals are mixed with spiritism. They just call the devils and push them out. And I actually was invited to teach in a spiritist university. And I didn't get my devils out of me, unfortunately, but I taught as usual. But and in South Africa, they opened a wonderful psychiatric hospital, and it did not work. Nobody came until they brought in the religious healers. So that's a very interesting, and I think that's another interesting route or way for research, which is interviewing and understanding better traditional healers. I invited for tea a shaman from the Amazon, 3 hours, to look into our differences and closeness, and I found we were practically the same with psychoanalysis, the basic principles and the different names. But I think that we have to go further in that, in trying to understand the understatements and the methods of traditional healers, because this is not just Asia. I heard from Christine Orf's for example, that most US veterans, they get money for their mental health recovery, but they are not told how. and the most of them go to Mexico to get ayahuasca. So we in the West, we also need to know about these traditional healers more, and it's better, more important even. Thank you.
It reminds me of the Chinese medicine when, there's a lot of talking about how Chinese medicine practitioners are actually like psychotherapists because they are not just looking at the symptoms because they want to, know the whole background and, in during the consultation, it is a lot of the clients, the patients talking about their experiences and what is, potentially causing their insomnia or difficulty with different body systems. So even in the popular media, they make movies about Chinese medicine practitioners are like psychotherapists in a way. So I can really relate to them.
Yeah, but I do think that somewhere we have moved very far away from fields like anthropology and sociology, and those traditions have a deeper engagement and approaches like more ethnographic approaches and those kind of things, which I think I can see that there are some shifts moving back towards that, which perhaps can enhance research in the direction that you're mentioning, Denise.
Right.
Priyanka, you raised your hand.
Yeah, it was such a wonderful presentation. Thank you so much. Especially the reflective questions at the end really stayed with me. And I've asked myself very similar questions. And in that spirit, I had a recent interaction with a client where there were so many different intersections, but to start with, they were of Indian origin, born and brought up in the US, right? Like two very like a Western and Eastern perspective in that sense. And I've worked with a lot of people who migrated, but those who have been raised with Indian values abroad was one of my first experiences, and I could see some very subtle, nuanced differences in how they played out. For example, when there was a confrontation to be had, I received an email versus the regular WhatsApp communication that we were, kind of otherwise used to. And it like that distance that was created through that email was very palpable for me. And given that post COVID telemental health and these geographical distances have been so almost blurred, I'm curious if others have had that experience and how to hold the sameness and the difference in these kind of cultural differences.
So, Priyanka, thanks for sharing. I can't say that I've had direct experience, working with, because typically where I work, we don't see people online who are in different geographical locations. So it's difficult for me to speak directly to your experience. I don't know if there's anyone else here in the room who might be able to respond. But I think culture, it's a very shifting process. The idea of home itself is, and where your values are, that keeps changing. And I think that can be quite challenging, for therapists like you've experienced. So I don't know if anyone else who works with the diaspora can have anything more to say on this.
And I suppose not only we shift, the client may also shift in response to the therapist. So it really depends on how we communicate or what they got from their perception of the therapist too, and how much we allow, like what Poornima said about needing permission to talk about these things. So how we as therapists can bring up potentially difficult conversations about our different identities.
Yeah. And I'm wondering if to start with just naming that in the room might be helpful. And based on the presentation today, that seemed like my takeaway. So thank you so much.
Yeah, if you feel that it is not too threatening, or sometimes if it is too threatening, then you may disclose a little bit more before inviting them to contribute. Because we don't know how they may feel to a particular thing that got pointed out.
Yeah. Thank you. Thank you so much.
Verinda?
Yeah. So hi, Harold, and hi, Poornima. A very nice session, very informative, and I would like to share my experience. Like in therapy sessions, like how Poornima said, the urban context client and the rural, they differ a lot. And when we get into that context, like in Indian philosophy, or when they come with that notion that I believe in the planetary positions in my Kundali. So because of this planet in my position in my Kundali, I'm suffering this. And even though you as a therapist, if you are in that attuned to that thing, the client feels more heard and more, they can explain it further because they are like you explained in the presentation that body language, sometimes they express via body language, sometimes they are channeling their thoughts through these kind of ways. And really it is very helpful to know that the way you explained it, and thank you so much. It was really very informative. Thank you so much.
Thank you. Denise, you have a question?
I was thinking that, thank you. I was thinking that the cultural intersections, or those of us who are interested in culture, we have a duty, which is to inform the rest of the world about psychosocial facts or sufferings, which are very specific to our cultures, and the rest of us see it very scarcely. I was very impressed. For example, of course, I knew it, but anyway, reminding in the brief report about the film, which said married at 10 and mother of 2 surviving children when 19. So this, you correct me, Poornima, but what I have read is that India has the highest rank of women suicide, with girls at 12 who commit suicide before forced marriage. And the loss of so many children, or the loss of girls when the government forces in China or India the obligation of, or the cultural customs which force people to let girls die, are very cultural specific features, and we need, the rest of us need to be informed. I was very shocked in the Netherlands. I attended a presentation by Doctors Without Frontiers, who were collecting money to buy, you'll be impressed, buy antidepressant medication for 90% of the population of Malawi, because they were depressed. They were depressed because mothers die at birth and because they lose half of their children. They don't need antidepressants, they need equity and healthcare. So, but I was very impressed at this. They are very good willing, but they were so wrong in their perception of what the real needs and sufferings were. So I think the rest of us need to more, each of us need to know more about what happens so frequently, and therefore you are experts in this and the rest of us are not.
Yeah, I think when we think about culture, there's also a reminder of the openness and humility. I think it is really important to think about, us not knowing the world as we see. Katie.
Yeah, no, I've been thinking all along, I guess, why is psychotherapy not just a very Western term? What are we trying to do? I know, I think one of the first statements you made, Harold, was about we shouldn't just culturally adapt, therapy and then assume that's good enough. And I feel like a lot of even the definition of psychotherapy and how it's done, and similar with this example from Denise, with the Western idea of medication will solve your issues. We just apply that to foreign countries without actually understanding the context. So I guess I'm wondering how we can tackle this, or how we can actually revamp this whole understanding of mental health care. And I'm not really sure where to start, or if actually psychotherapy is the best starting point for that.
That's such an important reflection, really. I think I really like that Denise talked about suffering, right? And I think that's such an important word, rather than just fitting people into different, DSM or ICD categories and then trying to work with that. And there are so many ways to help people. When you were speaking, Katie, I was just reminded by, like, if we're trying to bring down, let's say, suicide rates in a country, we can't do it just by evidence-based psychotherapy. So in some Asian contexts, what has really worked is, because there are often suicides by farmers when their crops fail, when the rain doesn't come in time and they lose money or they have debts. So one of the interventions that has really worked is for the government to not allow free sale of pesticides. So it's kept locked, and they have to come every month and take certain regulated amount and use it, and that is supervised. And that is an intervention that's brought down the rates of suicide significantly. Now, that's not psychotherapy, but it is psychotherapy, right? If you expand the definition and you say it is a means of responding to suffering, and it is a means of responding in a way that is meaningful in the person's context. So absolutely, I think we really need to rethink what is therapeutic, what is therapy, and so thank you so much for that.
Yeah, and also the role of the therapist can be broader. So for example, earlier we mentioned about the stigma. So in a lot of the work that we do is to help social workers to prepare to talk about what is psychotherapy, so that people can have a better understanding and reduce stigma, rather than just learning how to do better psychotherapy, because we need to get people in the door in the first place. So really thinking about our roles differently, could be education, could be mental health promotion, or could be even policies, like what Poornima talked about, working with governments and instilling policies that can potentially work, that goes beyond therapy. Yeah, you have a question?
Hi, thank you. I was trying to figure out technology and it's not working with me. So first,
your real hand.
Yeah, thanks. And first, thanks for this wonderful presentation. One of the things that was coming to mind for me, it's also the fact that we've been, at times, from more of a Western perspective, we've been seeing mental health in a more reductionist way. As the two of you were talking, these ideas of the body, these ideas of trauma, all these different things were coming up for me. And I was thinking about perhaps sort of an entry, it's more about wellness, sort of not dissecting this mind-body connection in a way, and that can be such an important entry point in so many cultures too. So that was coming up for me. At times, perhaps our biases, even in terms of how we're viewing mental health, right? How we're sort of separating things, and how important it might be to sort of have different ways of approaching it that we might be missing at times, so that kept coming with your presentation. So thank you so much.
Yeah, and in a less stigmatizing way, when we consider this part of wellness. All connected. Body and spiritual.
Now we have one more minute, but I think we're we're hoping for an SPR meeting, an Asia SPR meeting, or some kind of events. I don't know if there's more information about that.
Well, and I was saying that please let us share with us these meetings you have, the roundtables you had. I would have loved to come. Please share them with us.
Yeah, definitely. Yeah, when we have other roundtables or online events, then we definitely will share with the SPR group as well. Thank you.
Okay, so I just want to say thank you very, very much to our presenters for a fascinating presentation on a very, very important topic and for taking the time to be here and to take part in the Distinguished Researcher webinar. I also want to thank all of the attendees for being here and for participating and for the lively and very fascinating discussion that we had. I do want to mention that as the latest roundtable, this webinar has been recorded and will be shared in the near future on the SPR YouTube channel. So look forward to that and share with friends. I also just want to quickly remind everyone that the International SPR Conference is approaching and will be taking place in Krakow at the end of June, and that there is an option to attend remotely if you are not able to attend in person. So please take that into consideration. We are all very much looking forward to seeing all of you and having more of these very amazing discussions. So thank you all very, very much. Yeah.
Thank you.
Thank you. Thank you so much.
Thank you.
Thank you so much.